want to address the question of, is this true expansion or is this quote unquote just tipping? This is easily one of the themes that comes up time and time again that causes a lot of confusion for parents when they're trying to decide on what the appropriate next step is for their child and selecting an approach or a kind of appliance to use. So, the whole camp behind true expansion is in favor of things that would be referred to as like either rapid or slow palatal expander, typically. And then we're going to talk more and more about how there are other ways to expand when we are working in a growing child and why tipping isn't necessarily the bad guy either. So let's dive into this. In a moment, we'll shift back to kind of make that distinction between what I'm even talking about when I say the suture expansion versus the tipping. But here I just wanted to present to you the idea that when we are doing some sort of orthodontic movement, whether it's braces, or otherwise, there are different planes that we may be working in. So on this upper left, this is essentially working to adjust the width of the arch form, and that may be referred to as the transverse dimension. And so that's commonly what people think about when referring to this whole topic is that quadrant. But I also think it's important to point out that we have a more sort of forward, back, anterior, posterior, or sagittal expansion that can take place. We also have vertical changes, so more of a up, down type of change. And then also there can be changes in what we would refer to as like the frontal plane, because we're looking at it front on. So things like the midlines being off, where the center of the top two teeth may not meet up with the bottom two teeth, and we want to be doing something to get things in alignment. So even with that kind of bottom quadrant there, that's going to be kind of a last consideration if we have dental crowding or something otherwise that's sort of clouding our picture of what needs to be done. If there's a lot of crowding, then of course the midlines aren't going to match up. So you don't want to jump straight into like getting the midlines matched up if there's all this crowding that needs to be undone. When somebody is talking about sutural expansion, they are typically talking about the suture being kind of this really thin hairline joint of where one bone meets another. And when it's in the context of dental treatment, it's often that maxillary suture that runs through the roof of the mouth. The maxillary bone is the upper jawbone. So when there's pressure applied to that suture, what happens is gradually there is both naturally or through an appliance that's applying the pressure, there will be expansion there, and then the bone over time fills that in. So this is kind of a little like pictograph to demonstrate what's happening is there in the midline of the arch, things are being spread out in a width dimension, and you see that width increasing. And those teeth, instead of just separating, sometimes we do have, when you think about somebody getting rapid expansion, it will temporarily create this space between the front teeth. That is typically going to be short-lived, as the teeth will eventually sort of migrate to fill in the space that has been opened or created there. And over time, that bone fills in with new bone. We do also have something called dentoalveolar expansion. So the alveolar ridge, I've kind of put down here with a mountain ridge so you can kind of get that comparison. But that tooth sits up into a little ridge that sort of runs around the arch form. So what we can have is also the entire ridge can actually expand when pressure is applied to the teeth in an outward direction. The bone can sort of migrate with it or travel with it. and remodel. So I'm going to show you what that looks like here in a moment, but this is just to introduce this concept of dentoalveolar change. So instead of the force being applied through sort of that midline joint of the upper roof of the mouth area, all of the teeth instead are sort of pushed out, and the bone will, in the case of a growing child, still follow and remodel. This is just for you to be able to kind of see those little cartoon demonstrations side by side, in case that helps. So when I'm talking about the bone remodeling, this is the concept I want to introduce you to. When pressure is applied to the teeth, what will happen is there's an area of compression, which is the red area kind of indicated here with this red color, where the force is pushed in that direction. And what happens is the bone actually sends little signals to break up the bone structure that's there in response to that pressure. On the other side, there's going to be new formation of bone that sort of fills in what is left behind when that tooth moves. So this is to kind of demonstrate we have an original tooth position, we're going to move it to a new tooth position, and then you can sort of see the outline of where that original tooth was and where the new tooth is. There's like the outline of a root still there because we had bone that had to be remodeled. So this can happen in the upper row, was showing what would be referred to as like translational movement. So the root is moving and so is the crown of the tooth. When someone's describing tipping, what they're typically talking about is either the crown is moved or the root is moved, not the whole tooth is moved. And in this case, this demonstrates with the crown of the tooth being moved at an angle, and there's still going to be that bone area that breaks down because the tooth is moving into that space. And then there's going to still be an area that has to fill in new bone where the original tooth once was. And we end up with a new position, a tipped tooth, and it's still kind of within its alveolar ridge. That's the area that has done this remodeling. The upper jawbone and the lower jawbone are very different in terms of both how they're composed, the way that the bone is in each jawbone, and then also how they grow over time. So we talked about the suture that runs through the roof of the mouth, but we also have to recognize that the upper jawbone has a joint connection, a suture, with several other bones in the skull. And so it's not all simply about that upper midline joint. And what happens is the upper jawbone is actually, they call it more spongy bone because it is less dense than the lower jawbone. And what we can see here is the attempt to show you that the way that the upper jawbone grows is that there at the sutures is more bone that's grown, and as a result, things kind of grow away from those suture areas if we're looking more in the anterior posterior direction now. So thinking about this just to kind of put in context, a lot of times people ask why maybe cranial sacral therapy might be helpful. This is a good reason to explain. Part of that is that the upper jawbone connects to a lot of other bones, and we want to make sure that the body is adapting to the pressure that's being applied throughout kind of the whole system, not just looking at what's going on in the one maxilla upper bone. And these sutures, those little joints, actually will grow throughout adolescence. So starting from when we're young all the way through the teenage years. There is more of a understanding now. When I went through school, we were taught that the sutures fuse at a certain point, making them immobile, that there's no more growth happening, but there's also no movement happening. And now we're understanding more and more that there may not be any growth happening, but there is still some movement there. On the flip side, the lower jawbone is much more dense. It does initially have a little bit of a suture at kind of the midpoint of where one half of the lower jawbone meets the other half of the low jawbone, but that's fused by the end of the first year of life. So that's not where a growth takes place in the lower jawbone, unlike the upper jawbone. Our growth actually in the lower jawbone primarily is converting cartilage over time into bone in more of kind of a backwards and upwards direction. So that's the growth is happening in that kind of backwards and upwards way, but the result is the overall jawbone is still growing in a forward dimension, if that makes sense. It's a little bit backwards and confusing to think about, but it's an important distinction to make from how the upper jawbone is growing. And I like to point out that the signals for our growth, so part of what when people talk about myofunctional therapy and having the tongue be the natural palate expander during growth, it's because the tongue is naturally applying a certain amount of pressure to some of these sutures, and that is what sends that signal to grow. Similar to how an expander might work, it's sending a signal to grow. And with the tongue being the natural expander, it's also going to eventually become the natural retainer. But the tongue's not the only part of this equation. We really have to think about it with also the other muscles of the cheeks and the lips and how we chew and how we swallow. So the lateral movements and protrusion are how we're functioning, basically. Also important to note is just that the growth signals, they're not only coming from the muscles, right? We have growth signals coming from our jaw joint. We have growth signals coming from our teeth and the gum and bone support of our teeth. So how we chew sends certain signals to our body in terms of how the growth should be taking place. And also, like our hard and soft palate, I know everyone's so focused on that hard palate and the suture there, but also with our soft palate, how, again, our tongue actually does come up and come in contact with the soft palate too. And what we know is that a lot of other joints in the body, so joints from what we would call like the sphenoid bone meeting up with the occipital bone, there are different joints in our skull that are going to respond to how we swallow and things of that nature. So that's also driving how our skull on the whole is growing. It's not just about how the dental arch form is growing. Our teeth are really designed to kind of interlock in a certain pattern. And part of that is the upper teeth are intended to sit just outside of the lower teeth. And there's also kind of an ideal spacing that those teeth are meant to kind of land into. This photo is of dentures, so that's not really a real mouth. And then the sort of digital recreation is a little off in terms of how the front teeth look, but as it moves back around the back teeth, you can see that's a good demonstration of kind of the interlocking pattern that we are intended to develop. The reason this is important to understand is that how we chew and how we move our teeth and how we even close our teeth together can be affected when the teeth don't line up exactly right, that like the ideal situation. And really, anytime you hear the word malocclusion, it's just telling us that the teeth don't line up in this ideal format. So this is an example of some teeth that clearly don't line up in that ideal format. And we see that there's some breaking of the front teeth and chipping. I'm sure this patient has a lot of other issues that we're not immediately observing. But the reason I put this in here is to show you in an adult, if we can't get the teeth to close correctly, it's going to have effects on the jaw joint health. It's going to have effects It's going to kind of limit to a certain extent our range of motion when we go to chew, when we go to speak. The bone support for some of these teeth is going to end up being less than ideal. So this patient may be more predisposed to have things like gum recession or gum disease. So there's a lot of reasons why we want to set up a good support through the dentoalveolar support for these teeth early. And my analogy here that I want you to understand is when those teeth do sit in a really good position, we're going to pretend that this drawer, the drawer sliding out and sliding in might be the mandible, the lower jaw. The drawer kind of housing or where it kind of sets into is going to be the upper jaw. And when things line up perfectly, we know exactly how this is going to close together. So when that drawer is overcrowded or things are kind of piling up in there and there's clutter, too much going on, or just not even neatly arranged, then what's going to happen is there are going to be interferences that stop that drawer from being able to close together. So in this case, what's in the drawer is the teeth. The drawers themselves are the jaws, and we now have an interference preventing things from closing how they should. And I think that that's really important. This is a very oversimplified diagram of a skull. We've got a little pink spinal cord. The orange is the upper jaw. The sort of lilac color is the lower jaw. And our teal variations are the teeth. So a lot of times you'll hear dentists, orthodontists, or otherwise say, we have to often start with the transverse dimension or the width to decrowd that first. And then what we often see as a possibility with that is that from setting the upper jawbone into a better position, we're eliminating some of those interferences. When we look at someone and say they have a small lower jaw or a lower jaw that sits backwards, it might be because there were tooth interferences preventing the jaws from closing into that ideal interlocking tooth position. So sometimes, not every time, but we can see the lower jaw come forward a bit when the upper jaw is getting some expansion. Mind you, this is not the argument. I'm not saying that people only need upper jaw expansion. I do think in order to get those teeth sitting in a good interlocking position, we probably do need upper and lower jaws done at the same time in order to facilitate getting that good bite. So this is just an idea to present to you. If you're wondering how your child's lower jaw is ever going to come forward, this is something to think about. Now, there is rationale and basis for the reason why tipping gets kind of a bad rap. In an adult who hasn't gotten a properly developed alveolar ridge, a lot of times that bone and gum tissue is somewhat compromised. One more reason why we want to treat early. But what we can see happen when I say compromised, it's thinner than it should be. The support isn't there, or the teeth were crowded that interfered with how that gum and bone support developed in the first place. And now we're left with a situation where we have maybe some gum recession, or we have even the bone is too thin and it's being kind of broken down. The signals are being sent if we try and move the teeth through tipping or through translational movements, and we don't have the right bone support there in an adult who's no longer growing, we don't always have that ability to get those signals or that remodeling. And so it can lead to some unwanted outcomes. But this is much more common in an adult who's done growing. Or if expansion's done really quickly, it can be something to be concerned about. It's much less common of a concern in a growing child. So finally, I want to bring this back to that topic of tipping. So on the left side of the screen, I just have what I've presented before, a V-shaped arch versus a U-shaped arch. And, obviously a V-shaped arch, we do need some sort of expansion. How we're going to get there could be through a variety of ways. But this picture on the right side, I want you to appreciate this is a lower jaw. And what's happening is the width of the bone itself is maybe not all that bad, but the teeth, what they've done on the bottom jaw is they've tipped in towards the tongue. This may be because the upper jaw that belongs to this mouth is too small. And so the body is trying to compensate, trying to get that perfect ideal interlocking position as best as it can, knowing that the upper jaw is too small. And so sometimes we're going to expand the upper jaw through what we think about through conventional expansion, and the lower jaw may get some tipping of those teeth in order to try and get to that more ideal interlocking occlusion or bite position. So this is one example. It comes up pretty frequently when people say, oh, the lower jaw, it can't be expanded like the upper jaw can. That's true. It can't. It doesn't grow at the suture like the upper jaw does. But doing some sort of tipping or dentoalveolar expansion is still going to allow for significant improvement in the arch width, in the occlusion, and in where the tongue space can rest, how we breathe. There are certain things that it's setting up the stage for. And again, when we do all of this early, we're also setting up the gum and bone health for a higher chance of success without having some of those other problems I talked about. So hopefully this kind of connects the dots a little bit between why dental tipping is not always the enemy, but also I think it's really important because I hear so often people chiming in, no, this XYZ treatment can't be the right treatment for your child because it's not addressing sutural expansion. So outside of the sutural expansion, we may still see things like braces, Invisalign, tooth pillow, any of those kind of myofunctional appliances that can still make significant improvements outside of being a traditional expander. So let me know. Hopefully, this helps shed some light on some things for you. Let me know what other questions this raises for you. And yeah, thank you for listening.